I think neurodiversity is probably the hottest topic in all of mental health at the moment. We're going to speak about neurodiversity and some of the controversies, but also some of the opportunities surrounding this, because there's a lot going on in this space, and I'm going to kind of talk you through some of the key issues today. I just wanted to thank Annabelle and Robin Davidson for inviting me to speak. So some of you who know Robin may be wondering whether we're related. And last time I was here speaking to an audience like this, I did say Robin was my grandfather, but he was a bit put out by that. So I'm not going to say that this time. I'll leave you to draw your own conclusions. We are related. I'll leave you to draw your own conclusions. He's a wee bit more chronologically gifted than I am, let's put it that way. So I don't usually talk too much about myself, but I thought I'd tell you a little bit about me. I'm a general adult psychiatrist, and that in itself is when I got interested in neurodiversity and autism about 20 years ago, people just thought I was odd. I mean, people think I'm kind of odd anyway, but they thought I was odd particularly because I was a general adult psychiatrist with an interest in autism, because in those days it was seen very much as the domain of CAM psychiatrists and learning disability psychiatrists. But I've sort of developed that interest over the years. I'm a clinical lead of the Leeds NHS Adult Autism Service. And for the last 4 years, I've been the Royal College of Psychiatrists Autism Champion, so a kind of national role looking at autism training for psychiatrists, sort of sitting on the NHS England National Steering Body. I've just actually finished that term last month, so officially I'm no longer the autism champion, but I'm going to share some of the reflections and insights I've gained from that role over the last 4 years. This is the autism curve, and I've called it that after a BBC documentary, which you can actually still listen to on BBC Sounds, and it's worth, if you want a deep dive into this, it's worth listening to that. But this is from a paper by Ginny Russell, really kind of prominent autism researcher from a couple of years ago, and it maps the rise in autism diagnoses we've seen across the UK over the last 20 years, and you can see there's been it's gone up 4 times basically over that time in a sort of exponential curve. So this has raised a lot of questions. Some people have suggested that this is an epidemic of autism. I've realized when I was going through this the other night that I've got a few villains in this talk, so if you can see any more, there's 3 or 4 of them. Yeah, so Donald Trump, he's actually had quite a long-standing interest in autism, but his take is this is an epidemic of a serious disorder. There's something wrong, and there's something going on that's causing this kind of outbreak of autism in the US and the UK. And he particularly has just fingered Tylenol as the cause, which we would know as paracetamol. So pregnant women taking paracetamol sort of causing autism in their children. The guy behind him, who you may not recognize, is Robert F. Kennedy Jr., who's Trump's health secretary. Again, long history of getting interest in autism, but again, very much from this, it's an epidemic, we need to do something to stop the epidemic kind of point of view. And his big thing is that vaccines cause autism. So I thought I'd start off with, does paracetamol cause autism? And I mean, it's true to say that there are a few studies that find a modest link. There's one from Harvard in particular. But we have to remember that association is not causation. So just because it may be found that women who take paracetamol in pregnancy may be slightly more likely to have an autistic child, it doesn't mean that paracetamol is the cause. So there's other plausible mechanisms for that. We know, for example, that autistic people are more prone to joint laxity and joint hyperflexibility and joint pains. So it's quite plausible that autistic mums have more kind of joint pains in pregnancy and therefore take more paracetamol. And if they have a child who's autistic, it's not because they took paracetamol, it's because of the genetics, because mum was autistic as well. So once you actually control for those types of confounders, which they did in a big Swedish study with 2.4 million people, that link disappears. So actually, there isn't a link between taking paracetamol in pregnancy and having an autistic child. And the Medicines and Health Regulatory Authority have said as much in the wake of Trump's speech, and so has the World Health Organization, and actually so have we in the Royal College of Psychiatrists. Which is important, and it's irresponsible of people like Trump to say these things, because we had worried mums contacting us and saying, oh, I feel terrible, I had some paracetamol, I had a fever in pregnancy, took paracetamol, and is this, have I affected my child in some way? So it's really important to put these kind of conspiracy theories really to bed. The same with the vaccines one. The guy who came up with that was a guy called Andrew Wakefield in a study in the Lancet, and he was actually struck off because his research was found to be fraudulent. So, if it's not vaccines and not paracetamol, what does explain this autism curve, this dramatic rise in autism diagnoses we've seen? By the way, a similar pattern in ADHD as well. I'm going to take you through sort of the expert consensus, really, about the factors that actually do explain this rise. So, one of them is the diagnostic criteria that we use to diagnose autism. You may be aware there's diagnostic manuals that we use in mental health and psychiatry. So there's the DSM and the ICD. And back when I first got interested in autism 20 years ago, we were using the older versions of these, the DSM-4 and ICD-10, and now we've got DSM-5 and ICD-11. And so there's been some changes in the way autism is described and diagnosed in those manuals. There used to be a triad of impairments, and now there's a dyad. So to diagnose autism, you need to have evidence of social communication difficulties, and you need to have evidence of restricted repetitive behaviors and special interests, which we call RRBIs in the field. And often there's sensory issues. So the way that we define autism has changed slightly. Another thing that's changed, so to have a diagnosis of autistic disorder or autistic condition versus autistic traits, again, something I'll come back to later, these issues have to be present in early development and cause impairment of functioning. Now, the present in early development clause has changed slightly with the ICD-11 and DSM-5. So it used to be, we said these autistic features have to be there in early childhood, so really before age 5 or 6. Now we allow for the fact that in some autistic people, and this particularly applies to autistic girls, the features of autism aren't so apparent in early childhood. They sort of fly under the radar. And it's only often when social demands start to kind of exceed the person's social capacities that the features of autism emerge. And that's typically in high school or adolescence, when friendship groups become more complicated, social dynamics are more complicated. And so that's shifted the dial a little bit, particularly when it comes to diagnosing girls. And then the final thing that's changed is the various subtypes of autism, which included things like Kanner autism and Asperger syndrome and PDD-NOS. They've all been sort of merged and subsumed into this wider category of autism spectrum disorder, which on the one hand is good because it's simpler, and actually there weren't, strictly speaking, bright lines between those different subtypes. But on the other hand, what we now have is a situation where autism is a very kind of, it's an umbrella term, and there's lots of different presentations and different kind of levels of functioning within that term autism now. That does pose a challenge, I think, to policymakers, particularly when it comes to structuring services. Another thing that's changed in the last 20 years is the availability of autism assessment and the sort of capacity there is in the system to assess for autism. A particular landmark here is the passing of the Autism Act in 2009. Now that just applied to England and Wales, so I don't think it applies to the Isle of Man, but really the impact of that has ramified through the United Kingdom. And what the Autism Act said is that every region needs to have access to an autism pathway, autism diagnostic pathway. And so that catalyzed setting up lots of new autism clinics, including my clinic in Leeds. Before that, there was hardly any adult clinics, and now there's lots. So that's changed the dynamic in terms of recognition and diagnosis in adults. And then the final issue, just to point out, is increasing public awareness. So again, when I started in this field 20 years ago, a lot of people didn't know about autism, or maybe hadn't even heard of it, or it wasn't uncommon for my colleagues in general adult psychiatry to say there's no such thing as adult ADHD. I heard that multiple times in my training. But now pretty much everybody's heard of autism and ADHD, haven't they? And it's partly because of celebrities and more media interest. So we've had people like Christine McGuinness. She did some really good documentaries about being diagnosed as autistic as a woman in adulthood. Fern Brady, who's an autistic comedian. Anthony Hopkins, who is kind of unusual in some ways because he was diagnosed with autism in older age, which now I'll go on later to give you a bit of detail about the kind of age differential when it comes to autism, but it's still quite unusual to get older generation people coming forward for an autism assessment. I did assess somebody the other day who was 82, but that's the oldest I've ever seen. Elon Musk, so the villain, if you're playing villain bingo, here's perhaps another one. He's not, I used to say he's the richest man in the world, but apparently he's not. So last month he's now just the second richest man in the world. Larry Ellison is number one. But he's autistic, he's got Asperger's syndrome, and he's spoken publicly about that. And the final person here is Paige Lyle. So I've included her because she is a social media influencer, and she operates particularly on TikTok. So Robin, TikTok is a social media platform for young people. And she's got 2.5 million influencers on followers on TikTok. And I've included her because that's a big driver now in this increase in public recognition of social media. A really interesting paper published earlier this year about looking at the link between increasing ADHD and autism content on social media and that driving referral numbers. And a lot of the stuff on social media is good. Paige Lyle's videos are pretty good, I think, but there is quite a bit of misinformation on there as well. I mean, we had a sort of mini epidemic of Tourette's syndrome in and around the COVID pandemic, and it seemed to be linked to an upswing in Tourette's and tics videos on Instagram and TikTok. So all of this plays a part in increasing public awareness, and it's a kind of double-edged sword for us in the autism clinical community, because there's no doubt that the stigma around autism and ADHD is reduced significantly, but the interest has been driven up, and that drives up referral numbers. So these are the figures for England. I don't know what the figures are for the Isle of Man, but I would be surprised if you don't have a bit of a waiting time crisis here. But you can't even get an adult diagnosis? Right. Right, no adult pathway, right? Okay. It's unusual, to be fair, that there's no adult pathway, but it's not unusual that there's issues with access and wait time, because that's happening across the whole of the UK. So 250,000 people waiting for an autism assessment in England. That's adults and children. The figures for ADHD they're not centrally collected, so a bit harder to come by. But the estimate is there's 600,000. 600 million would be quite a figure. 600,000 people waiting for an ADHD assessment. So it's actually a massive chunk of the overall NHS waiting list issue. So what explains the autism curve? In my view, and this is a view shared by many experts in the field, it's to do with the changes in the diagnostic criteria, the increased availability of assessment, particularly for adults, the greater publicity and public awareness. Those are the big factors. I mean, we can't rule out some type of environmental causes having some impact. The COVID pandemic definitely seemed to have an impact. We saw a doubling in referrals for autism numbers, more or less overnight. Following the COVID pandemic, we saw a tripling in ADHD referral numbers following the pandemic. Social media and smartphones. There is some quite interesting studies linking increased severity of ADHD symptoms to increased smartphone use. So potentially that's an issue. But we can pretty definitively say it's not because of vaccines, not because of MMR, not because of diet, not because of parenting style. So there used to be this old-fashioned notion that refrigerator mothers could cause autism in their children, but thankfully that's been debunked. And not paracetamol taken in pregnancy. So this is taken directly from our Royal College of Psychiatrists autism information guidance. Right. Now, another thing we've seen, I would say particularly in the last year, I guess in response to this autism curve and this waiting time issue, is neurodiversity has captured the attention of pundits and politicians and policymakers. So people like Matthew Parris, who writes in The Times and The Spectator, he's written a lot about neurodiverse conditions being linked to this increase we've seen in young people claiming disability benefits, PIP benefit particularly. And politicians have kind of jumped on this. So Kemi Badenoch, the leader of the Conservatives, has spoken about autism and ADHD being almost like a golden ticket that allows you to have special privileges and get extra time in exams and reasonable adjustments at work. Nigel Farage, maybe, is he on the villain list? He says mental health conditions are overdiagnosed, and everybody always specifically mentions ADHD and autism as being overdiagnosed. But even Wes Streeting, of course, who's the health secretary for Labour, the Labour government, he has also spoken about overdiagnosis. Another sort of new front in this is around EHCP, which is special educational needs. I don't know if you have EHCPs on the Isle of Man or a sort of different system. This is going to be the next big political row. So Labour have had a row already about PIP, and the government were forced to back down by their backbenchers, but EHCP and special educational needs is the next big row on the horizon. And that's because EHCP, health and care plans for special educational needs kids, they've doubled over the last few years. And so there's pressure to raise the bar for access to EHCPs. And this kind of policy exchange document, which had the very emotive title of Out of Control, was basically all about increased numbers of ADHD and autism in young children and the pressure that's putting on the SEN system. And then this, as well, has added more fuel to this fire. A book published earlier this year by Suzanne O'Sullivan, who is a neurologist, so she's not a psychiatrist. But her book is all about over-medicalization in the Western world, particularly the UK and the USA. The book is not just about ADHD and autism, so it covers some physical health conditions as well, but ADHD and autism play a very big part in it. And I have it on good authority that Suzanne O'Sullivan has met with Wes Streeting and other Department of Health officials, and that they're very sympathetic to her arguments. So she would say that autism and ADHD rates have risen massively, which is true, we can't argue with that. But her other claims are more contentious. So she says that the vast majority of this increase is in milder cases. It's tricky to define what that exactly means, but you could argue that perhaps. She also says that, particularly in adults, a diagnosis of autism, it gives a kind of short-term relief because you feel more understood or you have better understanding from others. But she claims that it leads to worse outcomes in the longer term through a psychological mechanism called the labeling effect, where you take on a kind of sickness identity along with the diagnostic label, and then you do things like you quit your job or you like lose contact with your friends. And then the final claim that she makes in the book around autism and ADHD is that because we've seen so much of an increase, that the support services are getting overwhelmed, and then there's the most kind of severely affected people are missing out on the support they need. So I'm going to just sort of go through some of these claims and tell you what I think and what the evidence shows, and try and bring some balance to it, because these debates can get very polarized and bad-tempered very quickly. Okay, so just the first thing to point out is around this autism curve. And here the curve is broken down to male and female diagnoses. So the males are green and the females are red. And you can see that actually the bulk of the autism curve is because of increased diagnosis in women and girls. And I would say, a lot of people would say, is that that's because of it's a correction of a historic underdiagnosis and under-recognition in women and girls. So if you look at the literature around autism, and to a large extent ADHD, it's all about boys. It's about boys not talking and boys not socializing, boys being overactive and disruptive in the classroom. A lot of the diagnostic tools like the ADOS and the ADI and so on, they were designed with a male profile in mind. And it's only really in the last 10 years that we've understood that females can present slightly differently. There's this kind of perhaps slightly later age of onset. There's a different style of socializing. The types of special interests can be different. And so I think we've got better at identifying autism in girls and women, and who are kind of always there, but now are being recognized, and that's to the good. The other nuance within the autism curve is around age. So this is a paper Elizabeth O'Nyons and colleagues published about 2 years ago, and they broke down the rise in autism diagnosis, or the pattern of autism diagnosis according to age band. And you can see that in the teenage category, the rates of diagnosis are quite high. So 4% of teenage boys have an autism diagnosis. But as soon as you get into the older age ranges, particularly over the age of 40, those bars drop off dramatically. So autism is very under-recognized, under-diagnosed in older people. So the authors of this study estimate that there might be up to 600,000 people aged 50 plus who are autistic but undiagnosed in England. Turning to the impact of the diagnosis, so you might remember that in her book, Suzanne O'Sullivan said these diagnoses can cause the labeling effect, and they cause people to internalize a sickness identity and quit their jobs and whatnot. Actually, if you look at the evidence, most studies show, by and large, a very positive effect from an autism diagnosis. And the different elements to that, so a lot of our patients say they feel a sense of relief, they feel they've finally been understood, they say their family can understand them better, they can get access to better support at work, in school, they can reframe their past experiences through an autism or neurodiversity lens, they feel they have a more coherent identity. Lots and lots of benefits to a diagnosis. It can allow access to greater support. Some places have support services. Again, I don't know what it's like on the Isle of Man. To be in the mainland, post-diagnostic services are pretty underdeveloped in most places, it has to be said. So it is hard to get extra support post-diagnosis, but some people can do it. Having said that, really well-designed long-term cohort studies are lacking in this space, so we do need studies with longer-term follow-up to look at how the impact of diagnosis evolves over time. But looking at what evidence we have, I don't think Suzanne O'Sullivan's claim about the labeling effect particularly stands up to scrutiny. Yes, it's true that autistic people have difficulties. So high rates of mental health difficulty, high rates of suicidality, sadly, high rates of employment difficulty. But that's not caused by getting an autism diagnosis. That's because it's difficult being autistic. But people will like that anyway, even before the diagnosis. So I'm not convinced by this claim that a diagnosis can be sort of actively harmful. The other thing I just point out here is about the efficacy of ADHD treatments. So again, sometimes I hear people, not so much now, but particularly when I was training, saying ADHD medications, they don't work. They're just like speed and amphetamines. But actually, if you look at the actual evidence, ADHD medication have the biggest effect size of anything in psychiatry, including lithium for bipolar, or clozapine for schizophrenia, or CBT for anxiety, depression. And any of you who've worked in ADHD clinic settings, you'll have seen the impact that these medications can have. For some patients, it's absolutely life-changing. So it's a double scandal, really, that the waiting times for ADHD are even worse than they are for autism. And so many people, even if they have an ADHD diagnosis, they then can't get treatment. So, for example, a lot of GPs now are refusing to prescribe ADHD medication for people who've been diagnosed privately. And we've seen a big problem with just medication supply. Last year at least, it's been actually hard just to get ADHD medication because of disruption to supply. Now, I'm going to here talk about something, again, that's controversial. All this stuff is controversial, to be honest. But again, this is something controversial, but perhaps not very widely understood outside of the field. And that's about diagnostic threshold. So I think some members of the public think that going for an autism or an ADHD assessment is, you go, you see the expert, they do all these fancy tests, the ADOS, the ADI, whatever it may be, and then you get a very definitive answer. You're told you're definitely autistic, or you're definitely not autistic. However, really there's quite a lot of gray area, and this is particularly the case, I think, is to some extent in adolescent diagnostic practice, but certainly in adult diagnostic practice. Because there's probably about 1% of the population that are very clearly autistic. The bulk of the population don't really have any significant autistic traits. And then there's a significant chunk, probably about 5 to 10% of people that have some autistic traits or some difficulties that look like autism but might be because of something else. Say, a mental health condition, or have significant childhood trauma that has impacted their development. And they're the people, by and large, that we see in our adult assessment clinics. It's quite refreshing, really, to me when I see somebody who's like barn door or autistic, because the majority of people have all of these extra complexities. And so how do we make a diagnosis? Yes, we do use gold standard tools like the ADI and the ADOS, and we use the 3DI in our clinic as well. But ultimately, to draw the line, as it were, between somebody who's got autistic traits and autistic diagnosis, autistic condition, there's something called the diagnostic threshold. And to a large extent, what determines a diagnostic threshold is the degree of impairment. So there has to be significant impairment in functioning over several domains. So in employment, in relationships, in education. But it's problematic in some ways because it's a subjective threshold. I mean, a lot of stuff in psychiatry is subjective, but this is subjective. And it's dependent on the person's own perception of their difficulties. So can they identify them? Do they have insight into them? And can they communicate them effectively to the clinician? And then also dependent on the clinician's own judgment. So what they make of what the patient's telling them. And again, that's a subjective decision. So it has, I would say, been a bit of an open secret in the autism clinical community that for many years that diagnostic threshold differs between services and even between different clinicians. But just recently we've had actual hard evidence on this. So there was a study by Will Mandy, who's one of the leading autism researchers in the UK, looking at conversion rates between 3 different adult autism clinics in different parts of the country in England. Conversion rate is the proportion of your assessments that result in a positive diagnosis. So it's the proportion of people you diagnose, basically. And what Will and his team did, which was very clever, was they looked at these 3 sites, all in geographically different areas of the country, but they looked at all the people who were going to have the assessments before the assessment started, and they did demographic characteristics, they did a whole suite of psychometrics, including the AQ, and they looked at their characteristics across the board. And in all 3 sites, the pre-assessment characteristics were similar. There was no significant population differences in the 3 places. But then they went back and they looked at how many had been diagnosed with autism following their assessment. And there was this really kind of big difference. So site A diagnosed 31% of their punters, site B 69%, and site C 85%, which was kind of unwarranted given that there was no pre-assessment difference in the characteristics. So there's something going on there, and I think it's to do with the diagnostic threshold and where you sort of set your radar or set your bar. I think probably the other thing to say, again, we don't have very high levels of evidence on this, but there is a sense that in the private sector, the conversion rates are higher. So certainly there's some clinics where, they have 90% conversion rates, which seems unusually high. So, bringing all that together, is autism being overdiagnosed? I think, particularly when you look at the female diagnoses, that's perfectly justifiable and explicable. We've underdiagnosed females for decades, and now there's a long overdue correction. So much of the increase is because of that. And in any case, autism is still substantially underdiagnosed, underrecognized in certain groups. So older people, and sadly for actually both Robin and me, that includes, that's over 40. And psychiatric patients. I haven't spoken too much about the psychiatric patient issue, but there's good evidence that in the mental health system, autism is under-recognized because of a phenomenon called diagnostic overshadowing. Particularly probably an issue with autism in females being misdiagnosed as borderline personality disorder. Now, what I just spoke about, which is, as I say, probably not very well recognized outside the field, this unwarranted variation in conversion rates, I think it is a concern. And I think we need to work harder as a clinical community on harmonizing the conversion rates, harmonizing the diagnostic threshold, between services. But I would point out that even if you have a sort of slightly lower diagnostic threshold and you're perhaps diagnosing so-called milder cases, in my experience, those people still have very significant difficulties. I mean, you can't really get an autism diagnosis unless you have significant impairment of functioning and significant impact. So it's maybe a slightly different pattern. So it's maybe less social care needs, less support with activities of daily living, but more mental health, social engagement and employment type difficulties that we see in our clinics. And in terms of the impact of diagnosis, as I've said, it has a positive impact on well-being for the most part. Some people report after an autism or an ADHD diagnosis that there's an adjustment period and they may feel a sort of sense of loss or confusion for the first few weeks or months, but by and large, for the vast majority of people, the impact is positive. Moving on to the next controversy. Predominant model of autism when I was training was the medical model. And I am a doctor, right? So, this is how I was trained. The autism or ADHD, they're disorders. The person has a disorder. And the object of the diagnosis is to give them treatment to improve the disorder or to sort of coach or teach them to overcome it. But in recent years, the dominant model has become the neurodiversity model. So this has arisen from the social model of disability. And the insight here is that the person's not disordered, they're different, and that the aim of the diagnosis and the interventions is to make the world around them more inclusive, so improve the understanding of the people around them, give them reasonable adjustments and accommodations, and make the alien world more inclusive. And particularly on social media, these two models are kind of set up in conflict. And social media is all about conflict, isn't it? But if you go on something like Twitter and sort of advocate a more medical model point of view, you get shouted down pretty quickly in no uncertain terms. So again, the debate has got very kind of polarized and sometimes quite toxic, and there's people being booed off stage at autism conferences for, having too much, using the wrong terminology. And this is some of the kind of key differences between the medical model and the neurodiversity model. So I'm not going to read it all because there's a lot here, but a lot of it is around the terminology. So the traditional old-fashioned terminology was around disorder, the language of difficulties, deficits, symptoms, even the high and low functioning labels. The neurodiversity model is much more about positive language, talking about strengths, support needs rather than difficulties, differences rather than symptoms. And in terms of diagnosis, I think there's a shift in emphasis between the two models. So traditionally, diagnosis has been very much based on objective signs and symptoms made by professionals. I think on the neurodiversity, or sometimes called neuroaffirmative assessment model, there's much more weight placed on the patient's own experiences, their subjective experiences and their own interpretation of it, and even allowance for peer diagnosis, which is diagnosis made by other neurodivergent people, or even self-diagnosis, so much less role potentially for professionals, which is, can be a challenging space for somebody like me, who's a doctor. And then treatment, so under the medical model, it's legitimate to look for treatments for autism, and certainly that's the Trump and the RFK sort of approach. They're funding millions of dollars in research looking at autism treatments. The neurodiversity advocates would argue that's completely wrong-headed. Why should we want to treat something that's just a difference, a human variation? And all of the intervention has to be on reasonable adjustments and environmental adaptations. So, I mean, I'm sure a lot of you will have different views on this. So you can probably map the people in the audience according to whether you're more sympathetic to the medical model or more sympathetic to the neurodiversity model. I myself am a centrist dad. Like, my hero is Rory Stewart and the rest is politics. So I prefer not to try and frame this in such binary terms where it's one model sort of against the other. And we can think instead of a biopsychosocial model. I think as experienced clinicians and people who work in the field, we should be able to hold multiple perspectives at once. So for some people, autism very much is an identity. It's a sense of empowerment, acceptance, belonging. But for others, my patients tell me my autism is, to me, it's a disorder. If I could treat it, I would. And it causes me disability, and I need support. I need adjustments. I need to have disability rights. Increasingly, the approach we're taking is called a strengths and needs approach. So we're doing some research in our clinic, along with the University of Sheffield, around can we incorporate strengths and needs into somebody's assessment. So it's not just looking at their difficulties and deficits, it's bringing in their strengths and maximizing what they're good at as well. In terms of this language piece, I don't like the pathologizing language. I don't like particularly talking about autism as a disorder or talking about the symptoms of autism. But to be honest, it leaves me a bit cold at the neuroaffirmative language as well. I was told the other day I should be congratulating my patients when I diagnose them with autism. And I think it's not appropriate. So it might be appropriate for some people, but it's definitely not for all. So I advocate neutral, but clinically accurate and respectful language, and that's what we've really tried to do in our Royal College of Psychiatrists publications. And in terms of treatment, again, treatment has become a loaded word in this space, but we can talk about management, and it's about practical management plans, what actually works for that individual. And in many cases, that is about reasonable adjustments. It's about psychoeducation for the people around them. But in some cases, it will be like, what can the person themselves do? You know, if they're having really troublesome behaviors, why wouldn't you try and change those, as long as the person wants to change? So I think that there's a kind of balance to be struck here between these two positions. So that's one of the future directions I'd like to see, actually, is trying to achieve some accommodation between the medical model and the neurodiversity model and a sort of way forward, because it's turning into a bit of a kind of culture war, which isn't helpful for all neurodivergent people. Other future directions, well, just think about public policy for a minute. I won't dwell on this, because I know you've got a different legislation and policy in the Isle of Man, but in terms of the Autism Act, which I mentioned earlier, the House of Lords has currently put together a special inquiry committee to look at the impact of the Autism Act. So I gave evidence to that committee earlier this year, and it's going to publish its findings at the beginning of next year, I think. So look out for that. The Mental Health Act in England and Wales is currently undergoing an update. There's going to be a new Mental Health Act, and there's basically they have narrowed the criteria around autism. So it's going to be in future that you can't detain autistic-only people under the Mental Health Act for longer than 28 days. So the treatment section 3 isn't going to apply to just autism. And the reason for that is because there's an issue of autistic people being stuck in inappropriate placements under the Mental Health Act and suffering much higher rates of seclusion and restraint. And so this is one lever to try and stop that happening. Now, the other day, in preparation for this talk, I was looking at the Isle of Man Autism Spectrum Condition Strategy. So that's nice neutral language, and I was really impressed with this document. just recently published. It's a 10-year plan, very well written, and lots of very good and hopefully achievable goals in there. So I'd certainly commend this to you if you haven't had a look at it already. Okay, a few other new sort of directions in the field. So, clinical prioritization. This is, to be honest with you, just after the pandemic, when we had this doubling in referral numbers to our service, and we saw that across the whole country, we were swamped. So our wait list shot up to over 2 years. Patients were waiting kind of internally within our assessment pathway for a year or more between appointments. And it was like literally, I wasn't sleeping well at night because I was just so stressed about this situation. And I think sometimes that's a bit underlooked in these debates. As a clinician, we don't want to have long waiting lists. We don't want to have no adult autism pathway on the island or no post-diagnostic support. It's not a nice place for us to be as clinicians. So what we did in Leeds, and now various other places are adopting similar models, is we introduced a system of clinical prioritization, which is basically where we prioritize the sort of higher risk, higher need patients for a more timely assessment. We use a traffic light system, we use a RAG rating system, which is kind of traffic lights, so red, amber, green. So red are inpatients or people at imminent risk of admission, and we see them more or less straight away. Amber are patients with, say, high mental health needs or high risk of suicide or vulnerable population like looked after children or at risk of catastrophic life event like losing your job. And we'll see those patients within 13 weeks, which is the national waiting time target. And then green is everybody else, which is about 70% of our referral numbers, and they have to wait the full waiting time, which currently is 2.5 years. So it's not ideal. Obviously, I'd like to be seeing everybody within 13 weeks, but at least now I can kind of sleep at night because I know that we're seeing the really high need, high risk people quicker. Sort of slightly linked to that is a needs-led approach. So if those of you who go to sort of neurodiversity strategy meetings, you'll have heard the needs-led approach being mentioned. It's kind of attracting a lot of interest at the moment. The trouble is nobody can quite define exactly what the needs-led approach is or how to do it. So everybody, different places in England certainly are sort of developing their own models or developing even their own sort of needs assessment tools. So the idea is that you measure somebody's level of need and then you adjust the support you give according to their level of need. So it sounds good, it's a more personalized approach. It makes best use of our scarce resources in the health service. But there's a few issues with it. One is, as I say, nobody can quite agree what the best way of measuring needs is. So there's a risk that it just becomes a sort of almost like a postcode lottery with everybody doing their own thing. NHS England are interested in an international system of classifying functioning called the ICF, which is the World Health Organization approach. So it has some promise, but it's at the minute it's quite clunky and quite technical and not really, it's not easy to use. Other critiques of this is that basically it's a way of rationing services or even cutting services. We're only going to give autism or ADHD services to the top slice of people who have the highest need, or even assessments only to the top slice of people. And another criticism or critique is that actually consistently and fairly determining level of need and having a needs threshold, I think it probably suffers a lot of the same issues as the diagnostic threshold I spoke about earlier. I mean, it becomes a sort of subjective exercise, and there may be unwarranted variation. Other new direction, again, you'll hear this buzzword in strategy meetings, is about mainstreaming neurodiversity. not just autism assessment, but ADHD assessment as well. And this is in response to this mismatch of demand and supply. And there's 4 approaches to this that I've seen. So one is just to bring all the neurodiversity work within mainstream mental health services. So within CMHTs, if you're talking about adult services, community mental health teams. Within child psych services, it's often a bit different anyway. Sometimes pediatrics do some of the younger kids' assessments, sometimes CAMS do. Sometimes there's a separate neurodiversity service. Some places have developed some mental health specialist services, particularly perinatal and eating disorders, which see very high rates of neurodiversity, have started developing their own in-house assessment services for their groups of patients. We have some places that have a third sector offer, so it's not NHS, it's third sector people, and sometimes not qualified clinical staff, but third sector type peer workers and so on doing these assessments, particularly in Edinburgh, where I understand it's been quite a successful approach actually. And then this last one, really interesting development, is getting GPs to diagnose autism, assess autism. So in Cambridge, they have a research trial that's looking at whether GPs can diagnose autism in 3 10-minute appointments. So it'll be interesting to see if that is possible. I mean, I think my comment on this, particularly when it comes to the GPs and the CMHTs, is these guys are absolutely stressed out to the max already with their existing workload. The CMHTs and leads can't see all the people with schizophrenia and bipolar, never mind a whole bunch of autism and ADHD work on top of that. And God knows what the GPs would say if you tell them you're going to start doing autism and ADHD assessments on top of all your other work. Okay, so we're nearly at the end now. I've spoken quite a lot about controversies and difficult topics and stuff that causes quite a bit of rancor sometimes, particularly online. So I wanted to finish with some of the positives of autism in particular. This is a lovely poster developed by the University of Leeds, which really sets out some of those positives that we see in so many of our patients. And I think one of the strengths of our society is diversity, and that includes neurodiversity. And we've seen quite a few villains who probably aren't too keen on diversity, so Trump and Farage and Musk. But here's a hero, Greta Thunberg. She was just intercepted by the Israeli Navy, leading a flotilla of boats to Gaza. But she's a hero, particularly to my kids and probably your kids as well, a climate change activist. But Greta Thunberg is also autistic. And she's had some terrible attacks, really, from people who should know better, politicians and so on, saying, oh, you're like, it's weird. You've got a weird way of talking, you weird, intense eye contact, and what's a teenage girl doing worrying about climate change? You should be out at parties. So all these kind of ad hominem attacks and unfair attacks. And she has replied, oh, well, yeah, I'm autistic, actually. And to me, it's my superpower. It allows me to keep my focus on my climate change activism, have a strength of purpose, and to be able to speak truth to power. And I love this next little clip of Greta giving the death stare to the Donald at the UN. So I think that's a nice way to finish. Here's a few resources. I've mentioned the Royal College of Psychiatrists information resource. That's the one where we really tried to get the tone right and the balance right and the language neutral. There's a blog by me there about this whole overdiagnosis debate, and then the Autism Curve documentary as well worth a listen. So, thank you.